Okay, I think we will officially get started. Welcome. My name's Amanda, and I'm happy to see you all here today. As I mentioned, we're here to discuss the ESASr. Today's presentation is an encore presentation, which means a couple different things, and I will let Inga and Kathy get into that with you. But to begin, I'd actually like to go ahead and do our land acknowledgement. So today, we would like to acknowledge that the land in which we are gathered on is the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council, comprised of Chippewa, Beausoleil, Rama, and Georgina Island First Nations. Most recently, the Mississauga of the Credit River First Nation. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous people have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And as you know, we are here today. It's crazy to think, but I think we are in our third year of the Palliative Care Echo Project. This is a 5-year national initiative to cultivate communities of practice and establish continuous professional development amongst healthcare providers across Canada. So thank you for joining us, and we hope you've been enjoying the Echo Project so far. And we would also like to send out a special thank you to Health Canada for their financial contributions. Without their contributions, we would not be able to provide these sessions that we are continuing to do. Thank you. Now for introductions. My name is Amanda Tavalda, and I'm here with the North Simcoe Muskoka Hospice Palliative Care Network, and I am the Communications, Fundraising, and Community Relations Specialist. And I'm joined today by my colleagues, Kathy and Inga, who will both be taking you through today's session. Lady, the floor is all yours.
Thank you, Amanda. So my name is Inge de Bruin. I'm a palliative nurse consultant with the Palliative Care Network, have been for a long time. And I'm here with my colleague, Kathy.
Hi, I'm Kathy McEwen. I've been with the North Simcoe Muskoka Hospice Palliative Care Network for about 4 years now, and I'm looking forward to today's session.
Thanks, Kathy. So here is a QR code for you guys for afterwards to fill out a SurveyMonkey if you wouldn't mind. I think Amanda's going to put it in the chat later on after we're about done. So this is a little bit of a different recap that we're doing because we've done this ESASr tool presentation last year, Kathy and I, and that was videotaped. So we're going to show you the videotape, and then afterwards we're going to go into a couple of case studies and talk about that. Throughout the video, though, there's going to be some questions asked to fill out some stuff in the chat. You can just leave that be. We'll do that after we have watched the video with the case studies. So here we go into the video.
So these are the learning objectives that we will cover today. We will describe what the ESASr tool is. We will also describe the benefits and challenges when the ESASr tool is being used and describe how to implement the ESASr tool. So for the ease of discussion throughout this presentation, we will refer to the Edmonton Symptom Assessment System as the ESASr. So what is the Edmonton Symptom Assessment System? In the ESASr Administration Manual, which was written in August of 2018 and updated in November of 2019, it tells us that 1 out of every 4 Canadians will die of cancer. Prior to death, many advanced cancer patients experience significant symptom burden. Patients within 3 months of death are 2 to 4 times more likely to report moderate to severe symptoms than patients earlier in their illness trajectory. Approximately 60 to 80% of patients will experience pain before death. Other debilitating symptoms include anorexia, nausea, physical weakness, dyspnea, and delirium. These can occur with a similar or higher frequency. Psychological distress, such as depression or anxiety, is often associated with debilitating symptoms. Up to 30% of patients will experience an adjustment disorder, while 10 to 20% will develop a major depressive episode. Despite substantial symptom burden, advanced cancer patients' quality of life can be enhanced through appropriate symptom assessment and management. The need for routine symptom assessment in advanced cancer was recognized over 30 years ago when Brua and colleagues developed the Edmonton Symptom Assessment System. Although there are many other cancer symptom assessment tools, the ESASr is more widely used in palliative care and oncology programs throughout Canada. The ESASr is a comprehensive yet brief and practical self-reporting tool of symptom severity for 9 common symptoms plus 1. Here is an image of the screening tool. It has 9 symptoms. The 10th symptom is often used to assess for bowel function. And on the back of the ESASr tool is a diagram of the body where a patient can circle an area indicating where their pain is. And here's a graph associated with the ESASr tool where symptom scores can be transferred and evaluated over time to assess for trends with a particular symptom.
So the ESASr continues to dominate the symptom assessment field in advanced cancer and palliative care. It's a brief, comprehensive, and practical relevant to palliative care and entails minimal patient burden, which is particularly important for patients at end of life. The ESASr is used in many palliative care and oncology settings for the purpose of screening. This tool was translated into over 20 different languages. So a revised version of the ESASr, the ESASr, was created in November 2019 to address some of the concerns that were identified. So brief definitions were added for some of the symptoms. For tiredness, they added lack of energy. For drowsiness, feeling sleepy. For depression, feeling sad. For anxiety, feeling nervous. For well-being, how you feel overall. That was a really hard one before that. Appetite scoring reflects no lack of appetite to the worst possible lack of appetite. The time frame for symptom ratings was clarified to reflect in the moment. So it's specified as now. Related symptoms were grouped together. So you can see anxiety, depression, and well-being all grouped together. Another column was added for other symptoms, suggesting vowels as an example for constipation or diarrhea. So the ESASr is a screening tool for 9+1 symptoms in palliative care patients. It's a valuable part of a holistic comprehensive clinical assessment, and it's used in palliative care and oncology programs throughout Canada. So again, here is a slide of the 9+1 or the 10 symptoms. So 1 is pain, 2 is tiredness or lack of energy, 3 drowsiness or feeling sleepy, 4 is nausea, 5 appetite, 6 shortness of breath, 7 depression or feeling sad, 8 is anxiety, feeling nervous, 9 is well-being and how you feel overall, and 10 is bowels. So here again is an image of the actual screening tool. It has the 9+1 symptoms on there. See the check boxes on the right lower corner or right lower area. It gives an opportunity to record who is documenting the individual score. So I want to invite you guys to open up your chat box, and I want to hear from you if you guys are using the ESASr, how you're using it and where you're using it. So what is your current setting? So if you guys wouldn't mind sharing that with us, that'd be great. Nobody wants to share?
I have nobody in the chat box. In the clinic assessments, there are some people who are using it in long-term care palliative situations. Tammy.
Perfect. And Tammy, how are you using it?
Andy's house, they use it at hospice in the community. Community health nurses are using it for end-of-life programs with their clients.
Beautiful.
Yeah, it would be interesting to know how Tammy is using that in the long-term care.
Early integration of palliative care. Beautiful.
Yeah.
Thank you, guys.
Oh, as an initial assessment and then ongoing. Okay.
Wonderful. Thank you. Thank you
Perfect.
very much.
Thank you. So why do we use the ESASr? The goal of the ESASr is to determine the patient's perspective of symptoms. The ESASr helps to direct symptom management and to assess for treatment effects.
So how do we use the ESASr? So the patient should complete the ESASr or the ESASr with guidance from a healthcare professional, especially on the first occasion, just for clarification and guiding through. Instruct the patient to rate the severity of each symptom at that moment in time. And on a 0 to 10 scale, where 0 represents absence of a symptom and 10 represents the worst possible severity. So it's the patient's opinion of the severity of the symptoms that is the gold standard for symptom assessment. The body diagram on the reverse side, like we showed you before on the ESASr, can be used to indicate sites of pain. The circled numbers can be transcribed on the graph that we showed you before.
So who does the ESASr? For those patients, ideally the patient should fill out the ESASr on their own to reflect their own experience. And when the patient is unable to complete the tool independently, a healthcare professional may transcribe the ESASr score for the patient. The ESASr should not be completed by someone else if the patient cannot participate. So for those patients who cannot verbalize or who are cognitively impaired, the ESASr tool should not be used. There may be times where a patient cannot participate in performing the ESASr, but a caregiver who knows the patient well could complete the ESASr through objective assessment of the symptoms. The caregiver would not be able to score the symptoms, but could document in their narrative notes, for example, depression, the patient is tearful, or the patient has flat affect.
So when do we use the ESASr? So the ESASr captures the patterns of symptom severity at a point in time, but repeating the assessment will track the changes over time. And then if you want, you can put it on a graph. It's good practice to use the ESASr at an initial encounter with the patient and during each follow-up interaction. In community, the ESASr should be part of each symptom assessment. If symptoms are under good control, the ESASr might be done weekly instead of daily to decrease patient burden. In hospice or hospital settings, the ESASr should be completed regularly, like for example, daily or every shift if there's a significant symptom concern.
So where can ESASr be used? The ESASr can be used in any care setting where there are palliative patients. So in the hospital, the community, and the retirement homes. The ESASr is used to a lesser extent in long-term care facilities due to a large number of residents who are cognitively impaired or who have dementia.
So now we've got the scores. What do we do with those scores? Scores 3 or less continue current management and nursing care, continue ongoing reassessments. If the score is 4 to 6, further assessment is required with the goal to stabilize that symptom to an ESASr score of 3 or less within 12 hours. A score 7 or greater, we consider the symptom unstable. This requires urgent action with the goal to stabilize that symptom to an ESASr score of 5 or less within 4 to 6 hours, and then continuing to stabilize the symptoms to a score of 3 or less in 12 hours. However, we do need to take in consideration goals of care for individuals' needs and wants for symptom management. Consider culture and history and past experiences of a person. Perhaps they need to experience the symptoms within their belief system. So what do we do for further assessment? If scores higher than 4, and depending on the person's goals of care, we require further action with respect to a full assessment. We recommend using the system assessment acronym or the alphabet tool, the OPQRSTUV tool. A palliative approach to care with involvement of a multidisciplinary team would be most beneficial at that point.
So some things to consider. So when you're using the ESASr tool repeatedly with a patient, do you see any trends occurring? Remember that all 9 symptoms are what the patient is experiencing. This should always be subjective information. As practitioners using the palliative approach to care, we are always striving to treat our patients in a holistic manner, and we want that person to be in balance, as symptoms can affect each other. Often once one symptom has been brought under control, the other symptoms will also decrease in severity. For example, a patient's stress can cause sometimes symptoms to arise, such as pain, anxiety, or even depression, to name just a few. We can attempt to bring symptoms under control by either changing their treatments or by increasing their supports and services, but we must also continue to reassess symptoms at every opportunity. So if everyone could open up their microphones, maybe we can talk through some of these case studies.
So that was the video that was taped from last year, and there's not any changes that I can see. Any questions on the video? None? Then I think we're going to go into our first case study.
Oh, sorry. I did have a question. I wondered
ahead.
if there were recommended resources for folks that have cognitive challenges, if there's either an alternate way to use the ESASr, maybe using narrative, but also if there are any other tools that complement or are used instead of.
So thank you for that question. That's a great question. In the cognitively impaired people, there's different tools that we can use for different things. For sure, for pain, there is a couple. There's a pain ed out there. There's the Abbey scale. There's multiple out there that you can find online to use. But as far as we are talking about ESASr for today, we cannot use the ESASr when a person is cognitively impaired. Everything is subjective. So it wouldn't be a fair presentation of what's happening with the person. And we don't want to miss anything, right? So we have to find different ways different tools to support us in that way. Thank you, Amanda. Amanda put some other tools or a link to tools in our virtual resource binder in the chat for us. So let's go to the first case study. George is an 88-year-old male living alone in the community. He is still driving, has some support for housekeeping and meal prep. He has a diagnosis of CHF and AFib and COPD. He's had AMI and chronic renal disease. He drove himself to the ER. So when he gets there, they do the ESASr score and they show shortness of breath is a 6 to 7 out of 10. Pain is 5. He does not have anxiety, depression. Appetite is good. Slight tiredness at 2. Not drowsy. No nausea. Overall well-being is fine, and the bowels are working fine. So I'm going to ask you guys to put in the chat what our next step would be for George. What do you think we can help him with?
Nothing yet.
No, I'm looking to.
Further assessment of pain and shortness of breath.
Yeah, because those are the highest ones, right? Yeah, for sure.
Mm-hmm.
Yeah.
Further assessment of shortness of breath and pain using the OPQ-URS-TUV came from Leona. Perfect.
So any symptom that is higher than at least a 4 or 5, we have to look at and bring down as soon as we can, if that's in the goals of care for this person. So yeah, let's look at a multidisciplinary team, a holistic palliative approach to care for this gentleman, see who we can pull in to support him and get his shortness of breath and pain under better control. He might be more short of breath because his pain is up, but we have to do a full assessment to see where everything is coming from. So well done. Let's go to our next case study. Kathy, I'm handing it over to you.
Okay, so Gabriella is a 52-year-old female. She has been admitted to the hospital 3 days ago with pain due to bowel obstruction from cancer of the colon. She has a supportive husband and an 18-year-old son at home. She was diagnosed 3 years ago and has had surgery, chemo, and radiation. She has been in remission for about 1 year. So she's here in the hospital. Her pain is a 7. The ones that are up high, I'm going to read out. So pain is a 7, nausea is 6. Her anxiety is a 6, her well-being is 6, and her bowels are 6. So what do you think we'll do with her? Okay. Sure. Leona said that she would probably consult with palliative care team after giving her something for pain. So what might you say to, right, depending on the goals of care and which symptoms she wants to deal with first? Absolutely, Laura. Thank you. Yes, so probably when we see, refer to spiritual care, psychotherapists, social work to help assess anxiety and well-being. Very good. Thank you, Terry. Is there anyone else with any other thoughts? Okay, so when we're looking at these scores that are scoring high, like pain, nausea for sure, you may want to, investigate with Gabriella which ones are most distressing to her, all of these high numbers. My feeling is that we would have to investigate these symptoms a little deeper, like her pain and her nausea, using the OPQ-URS-TUV. And then hopefully, if we were able to get her pain managed and her nausea managed also, her anxiety and well-being may improve. Her bowels are 6 out of 10, but she is obstructed. So therefore, she may be without a bowel movement for a bit until they're able to get that settled out, if they can. I mean, she may not be a candidate for any further treatment. So this could be a real source for her anxiety also. But usually once pain and things like pain and nausea, these physical symptoms are settled, a lot of times anxiety and well-being will settle down also. Everything will come in together, right? They all kind of attach to each other, these symptoms. When one is out of whack, they're all kind of going to be out of whack. Does anyone have any questions regarding Gabriella? Any further questions or any other? Okay, well, great. We'll just move on then.
Move on to the last one, the last case study. Walter is a 78-year-old male. He's living in a long-term care facility with a diagnosis of dementia. He needs help with all ADLs, but is walking without any aids. His speech is now limited, and he is not able to participate in any conversation. In the past week, he is showing signs of discomfort through facial grimacing, agitation, and calling out. So the ESASr score here on paper are pain is 5. He's got a little bit of drowsiness, a little bit of anxiety, and his bowels are 5. So what would be our way to support Walter in the long-term care facility? Any thoughts on the ESASr scores here?
Leona says perhaps the ESASr could not be a true picture due to dementia.
Very well, you guys listened. And Daniela, thank you for bringing that up.
Yes, they're all answering that because, yeah.
Yes. So like I said before, the ESASr scores should not be done with Walter. He is cognitively not intact, so he can't give us those very subjective, that information that we are looking for. However, we can use like an Abbey scale or a PainEd or any of the other tools. There's quite a few good tools out there to see if he falls within that area of that he might be having pain. If we then perhaps give him a trial, an opioid, a low dose opioid, to see if that is really what is happening, and perhaps in his anxiety and his agitation and calling out will come down as well. So again, you got to look at a person very holistically, because like Kathy said, if one thing goes out of whack, then it affects the rest. I always see ourselves as a balloon or a ball being in balance. If you pull on one end of that string of the ball or the roundness of the ball, it will pull on all the other things. So make sure you look at pulling in anybody from the team that has perhaps some expertise in another area that might be helpful to figure out what is happening with this person, especially if we're looking at the people that are cognitively not as strong as perhaps other people. Any questions, guys? Because this is going to be the last case study, and I'm going to put up some of the references. We're going to be going into the end of the presentation. Any questions? You can open up your microphone if you want, shout it out. Sometimes easier than typing.
In the meantime, I've added in a couple of links into the chat there. The ESASr presentation was part of our larger series, Tools in Your Toolbox. So I've added in the link to our YouTube playlist where people can get caught up on the other videos, as well as our overall YouTube page, and a link to the satisfaction survey as well. And if anyone has any questions, feel free to unmute yourselves, jump in. We can have a chat with Inga and Kathy.
Oh, hi there. I just had another question about the well-being score. I find sometimes people are not entirely sure how to answer or what it means. I wondered if you had suggested prompts to help them respond.
So what I normally ask is, how do you feel overall? That's kind of the wording they've given it after they've done the reassessment on the ESASr scoring tool. Sometimes I put it, if I still don't get a lot of information, how do you feel in your heart? And then from there on, I will then go into what is most troubling you to try and figure out where to support this person the best way that you can. And sometimes it's very hard for people to give wording to things like that. You know, it depends where you're coming from, what your history is, how you've been brought up, and how easy it is to talk about certain things. But thank you for those questions. So those are
Excellent question.
great questions. Hope that helps out, Daniela.
Very much so. Thank you.
You're welcome. Any other questions, guys?
Well, I would like to say thank you, Kathy and Inga, so much. That was wonderful. And I love the fact that this was one of our topics to bring back by popular demand. It was just as good today as it was when we originally recorded it. So thank you so very much. And if anyone has any questions after the fact, you will receive a follow-up email with all of these links that we've listed here. Don't hesitate to reach out. If something comes up and you think of something else afterwards, feel free to reach out at any time. Kathy and Inga's information is on our website, and also our education contacts will also be in touch.
Thank you.
Bye-bye, everybody.